Hi everyone, I'm Dr. Divya Shanthi and welcome to NEET PG Core Revision series. These series are structured, focused and exam oriented so that you can recall faster and more quickly and more confidently in your exams. So in today's session, we are going to break down the anatomy of two closely related organs, that is the duodenum and the pancreas, into clear, high-yielding, exam-focused concepts. So let's get started. The duodenum was named by 𝗘𝗅𝗵𝗂𝗧, which means the width of 12 fingers. It is 𝗨𝗐𝗑𝗧, which means it is a width of 12 fingers. So a duodenum is basically a Latin word which is derived from the Greek word 𝗨𝗐𝗑𝗧. So this duodenum is the shortest, is the shortest and widest and the most fixed part of the small intestine. Okay, so usually when we say small intestine, it includes duodenum, jejunum and ileum. The jejunum and ileum, because they are freely mobile, we call them as the small intestine proper, whereas duodenum is fixed. So this duodenum, it extends from the pylorus up to the duodenum. So from here, from the pyloric end, okay, pylorus up to the duodenojejunal flexure. Okay, it up to there, it extends. So this duodenum is about 10 centimeters, 10 inches or 25 centimeters. Okay, 10 inches or 25 centimeters long. So it begins at the level of pylorus and that part it lies in the transpyloric plane. Now the entire duodenum is retroperitoneal, okay, except the proximal, okay, except for the proximal 2.5 centimeters, rest of it, it's all retroperitoneum, where this one will be suspended above by the lesser omentum. So the main function of the duodenum is mainly it helps in digestion. So here what happens, the chyme which comes from the stomach is mixed with both the pancreatic as well as the bile. Okay, so bile and the pancreatic enzymes are released, okay, here into the second part of the duodenum here, and it helps in the further digestion. So that is the main function of the duodenum. So the duodenum, when we see here, it is a C-shaped lobe of the small intestine, and the concavity of it will be enclosing the head of the pancreas. So this is the pancreas here. So the concavity will be enclosing the head. So it is located in the abdominal cavity above the level of the umbilicus, opposite to L1, L2 and L3 vertebrae. Okay, so it will be in relation to this. So coming to the parts. So for descriptive purposes, the 25 centimeter long duodenum is divided into 4 parts. The first part, which we call it as this is the first part. So first part we call it as the superior part, okay, and the superior part is about 5 centimeters or 2 inches long, okay, 5 centimeters in length. Then we have the second part. It is the descending part. Okay, so this is the descending, which is about 7.5 centimeters or 3 inches in length. And then we have the third part. Okay, so this is the third part, which is horizontal, and it measures about 10 centimeters in length. And then we have the ascending, that is the fourth part, which we call it as the ascending part, and that is about 2.5 centimeter in length. So that is about the parts of the 4 parts of the duodenum. So the first part of the duodenum here, we'll just look at some of the main features and very important structures in relation there. So the first part, which begins at the pylorus, okay, and it is about 2.5 centimeter in length. So this one, it ends at the superior duodenal flexure, okay, at the level of superior duodenal flexure, and becomes continuous with the second part. So here what important things we have to remember about the first part is, it is developed from the foregut, okay. Duodenum is derived from both foregut as well as midgut, but this first part is entirely derived from the foregut. It is the only part which is only partly that is covered by the peritoneum, and partly only small part is retroperitoneal. It is partly retroperitoneal. Then it is freely mobile. And it can distend. And it has no circular. So if you see here, it has no circular folds. Seeing here, we can see circular folds, but here there are no circular folds. Folds of the mucous membrane. And so this, the initial 2.5 centimeters, this is seen as duodenal cap. Okay, so when we see X-ray, it looks like the duodenal. It is seen as the duodenal cap in an X-ray. That is barium meal radiographs. Okay, duodenal cap in a barium meal X-ray. Barium meal radiograph. And this is the site for duodenal ulcer. Duodenal ulcer, okay. And it is supplied by the branches of the, since it is derived from the foregut, it is supplied by the branches of the celiac trunk. So here the relations, when we come to the relations, the important relations here which you need to know is, basically anteriorly there will be the quadrate lobe of the liver. So anteriorly we will see the quadrate lobe of liver. And we will also see the gallbladder. Posteriorly, okay, so posteriorly here, posterior to that, we will see the portal vein. So that is important. Portal vein is seen. Then we see the gastroduodenal artery. Gastroduodenal artery. And common bile duct. These three structures are seen posteriorly. So that is very important. And superiorly there will be the epiploic foramen. So epiploic foramen is that part which the greater sac and the lesser sac will communicate. And then we have inferiorly we will have the head and neck of the pancreas here, you can see. So inferiorly this portion will be the head and neck of the pancreas is seen. So these are the basically the relations of the first part of the duodenum. In the second part of the duodenum, the interior of the duodenum is also important here. So here we see the circular folds, okay. So in the second part, the mucous membrane presents the circular folds which we call it as the valves of Kerr-Ring. Valves of Kerr-Ring. Okay, so these are the valves of Kerr-Ring. And in addition to this, okay, so we did not see any mucosal folds in the first part, but it begins from the second part, and we call them as the valves of Kerr-Ring. In addition, there is one major duodenal papillae. Okay, so here we can see, so this is the major duodenal papillae. So this major duodenal papillae will be about 8 to 10 centimeters distal to the pylorus, okay. And on its summit, okay, so on its summit, the common hepatopancreatic duct. So you can see here, the formed by the union of the bile as well as the main pancreatic duct. So it will open here, okay. So the common hepatopancreatic, so hepatopancreatic duct will open there. Then there is this minor duodenal papillae. Okay, papilla. So this is a small conical one here, about 2 centimeter proximal to the major duodenal. Okay, so it will be 2 centimeter proximal to major duodenal papillae. So here the accessory pancreatic duct. Okay, so the accessory pancreatic duct opens there. Then here we also see the arch of 𝗕𝗵𝗃𝗃 circularis. Okay, so arch of 𝗕𝗵𝗃𝗃 circularis, like a hood, monk's hood, we see it above the major duodenal papillae. So here we call it as the arch of 𝗕𝗵𝗃𝗃 circularis, semicircularis actually. Okay, arch of 𝗕𝗵𝗃𝗃 semicircularis, we see it above the major duodenal papillae as the monk's hood. Then below that there will be longitudinal folds, which we call it as the 𝗕𝗵𝗃 longitudinalis. So actually these folds, right, they help in identifying the major duodenal papillae. Okay, so here the peculiarities which include, it is the only part, that is the first few inches, which is intraperitoneal, and so it is really movable. Then it is the only part which is supplied by end arteries. So that is one of the reasons why the duodenal ulcers are common too. And it is the only part which is devoid of the circular folds. Okay, circular mucous folds. So these are the peculiar features. All these peculiar features you need to remember, because that is how they are asked in the exam to rule out. Okay, all of the following are true except kind of thing questions include these peculiarities. So here, this is how you can see in the barium Needle X-ray as the duodenal cap. Then coming to the second part of the duodenum, so it will extend, that is begins from the superior duodenal flexure and up to the inferior duodenal flexure. Okay, so it measured about 7.5 centimeters long. Okay, at the inferior duodenal flexure, it becomes continuous with the horizontal part. So here, what are the peculiarities of it? So here, the upper half will be, so the upper half is from the foregut and the lower half is from the midgut. So this portion will be lying behind the transverse colon, and here if we see, it will receive the bile duct. Okay, it will receive the bile duct as well as the main, that is the chief and the accessory pancreatic ducts also open within this second part of the duodenum. And it is the only part of the intestine supplied by the double rows of vasa recti. Okay, vasa recti, which arises from the anterior and posterior pancreatico-duodenal arteries. Okay, so from that, the vasa recti, straight arteries, they begin. So here it is supplied by the double row of this vasa recti. So coming from this arterial arcades. Okay. So relations here. So relations, when we see anteriorly, it will be related to, anteriorly it has the gallbladder and the right lobe of the liver. Gallbladder and right lobe of liver, as well as transverse colon, transverse mesocolon are present there, and a few coils of small intestine can be seen. So posteriorly it is related to the right kidney and the renal vessels, as well as the right border of this inferior vena cava is also related there, and psoas major muscle is also in relation there. Right, psoas major muscle. So medially when we see, so medially here we will see the head of the pancreas. And laterally from below we'll have the ascending colon and the right colic flexure as well as the right lobe of the liver is also in relation there. Okay, so that is the relations of the second part. There is this ligament which we also called as the suspensory muscle, okay, the ligament of Treitz, or it is also called as the suspensory muscle of duodenum. So what is it? It is actually a fibromuscular band. So this one, if you see here, it suspends the duodenojejunal flexure. Okay, so at this point, it will suspend this duodenojejunal flexure from the right crus of the diaphragm. This is the right crus of diaphragm, and this is the duodenojejunal flexure. So it will suspend that. Okay. So this band, okay, so what is the peculiarity of this band is in the upper part, okay, so upper part it will have skeletal muscle, that is the striated muscles are present in the upper part. Then in the elastic fibers in the middle part, in the middle, and in the lower part smooth muscles, okay, or non-striated muscle. Smooth muscle is present in the lower part. So this duodenojejunal flexure, the ligament of Treitz, it will prevent this duodenojejunal flexure from being dragged down, okay, by the weight of the loops of the small intestine, that is the jejunum and ileum. And also it is a very important landmark, okay, it's an important landmark for what? In the radiological diagnosis, okay, radiological diagnosis of incomplete rotation or malrotation, incomplete rotation or malrotation also of the small intestine. So that is the importance of this ligament of Treitz, otherwise called as the suspensory muscle of the duodenum. So this ligament, and an interesting fact about this ligament of Treitz is the shape of the duodenum also depends on the length of this ligament of Treitz. Okay, so if it is short, okay, short, it will be O-shaped, the duodenum. And if it is long, the duodenum will be reverse, that is reverse J shape. So if the ligament is short, then it will be O-shaped, the duodenum. Okay. If it is long, it will be reverse J shaped. Okay, and normally otherwise we will see the C shaped. So 3 shape of duodenum we can see. Okay. And sometimes this ligament of Treitz, it can kink the duodenojejunal flexure and can cause partial obstruction too. So that is about the clinical importance and the main features of ligament of Treitz. Then we have the duodenal recesses. Okay, so we discussed about the first part and the second part mainly because they are more important there. And next is coming to the duodenal recesses. So when we see the duodenal recesses of the fossa, what happens is they are nothing but the small pockets of, they are the pockets of peritoneum, pocket-like pouches of peritoneum. Okay, so they are peritoneal pouches. So what is the importance of this duodenal recesses? Sometimes it can lead to strangulated retroperitoneal hernia. Okay, so we have the superior duodenal. So this is the superior duodenal recess. So superior duodenal recess, it lies left to the upper end of the fourth part, okay, of the duodenum. And then we have the inferior duodenal recess. Inferior duodenal recess. So this lies a little below the superior duodenal recess. Then we have the paraduodenal recess. This is the paraduodenal recess. So this will be, it is the lowest one, okay. So the paraduodenal is the lowest one. And this paraduodenal, it lies left to the fourth part of the duodenum behind the paraduodenal fold of peritoneum. Usually this paraduodenal fold will be containing the inferior mesenteric vein, okay. So it will be in relation to that. So that is what we are seeing here. This is the inferior mesenteric vein. Inferior mesenteric vein, okay. So this paraduodenal recess will be just behind the paraduodenal fold, which contains the inferior mesenteric vein. Then we have the retroduodenal recess. This is the retroduodenal recess, and this is the largest of the duodenal recess. But though it is largest, it is rarely present. So it may not be there always in all the individuals. So it is rarely present. If present, it is the largest. So it will be lying behind the third and fourth part of the duodenum. Then we have a smaller one. This is actually mesenteroparietal recess, which this is mesenteroparietal. So mesenteroparietal recess is rarely seen. It is seen only in 1% of the individuals. It lies below the duodenum behind the upper part of the mesentery. Okay, upper part of the mesentery. So here near this anterior wall, we see the superior mesenteric vessels. So these are the superior mesenteric vessels we will see in the anterior part. That is about the duodenal recesses. Okay. So usually the superior duodenal recess is more common. We see it among the more common. Next, inferior duodenal, almost in 75%. So that is the most common here. Paraduodenal in 20% we see. Okay, and retroduodenal is occasional, rarely present. Mesenteroparietal is also very rare one. So now moving on to the arterial supply of the duodenum. So duodenum is derived both from the foregut as well as from the midgut. So the upper half is derived, okay. So upper half, that includes the first part and the upper half of the second part, they are derived from the celiac trunk, okay. So the first part plus upper half of second part, okay, it is supplied by the branches of celiac trunk. And that the lower half of the duodenum, okay, lower half of the second part and lower half of second part plus third and the fourth are supplied by branches of superior mesenteric, okay, superior mesenteric, because this is the mesenteric artery, this is the artery of midgut, and this is the artery of foregut. Right. So here if we see, the arteries which will be supplying will be the superior pancreatico-duodenal artery. Okay, superior. So the artery supplying will be the superior pancreatico-duodenal artery. So I'll repeat that here. So the arteries, main arteries which will be supplying the duodenum will be the superior pancreatico-duodenal artery. Okay, so this one here is the superior pancreatico-duodenal artery. So this is basically a branch, okay, so from the gastroduodenal. So we can see this is the gastroduodenal, which is a branch from the hepatic. So superior pancreatico-duodenal artery supplies. Then we have the inferior pancreatico-duodenal. Inferior pancreatico-duodenal. So inferior pancreatico-duodenal is a branch from the superior mesenteric artery. Okay. So this will divide into anterior and posterior branches here, which you can see, and it will be supplying through the vasa recti. Okay. So they form the arterial arcade, and through its vasa recti it supplies. So we can see the double vasa recti here, especially for the supplying the second part. Then we have the supraduodenal artery of Vældtke. Okay, so supraduodenal artery of Vældtke. So supraduodenal artery is here. It's a branch. Supraduodenal artery of Vældtke. Okay, it is the supraduodenal artery of Vældtke. So it's a branch from the gastroduodenal, which we can see. Then also retroduodenal branches from the gastroduodenal artery will supply. Then from the hepatic artery also branches, leash of arteries will supply, as well as branches from 𝗕𝗵𝗄𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏𝗏 𝗕𝗵𝗵𝗀 as well as artery from the first duodenal, from the first jejunal. From the first jejunal branch of superior mesenteric artery. Here you can see. This is the artery from the first jejunal branch of superior mesenteric. Will also supply. So that is the arterial supply. So here the arteries, that is supraduodenal artery of Wilkie. Then we have retroduodenal artery. Retroduodenal artery also branches from the gastroduodenal as well as the leashes from the hepatic artery. All of them, they supply only the first part of the duodenum. So that is very important, especially the supraduodenal artery of Wilkie. Sometimes it is asked, it supplies only, it supplies only the first part of the duodenum. So the venous drainage, it corresponds to the arteries. And they drain, basically they finally drain into the splenic, superior mesenteric, and to the portal vein. So final drainage is into these veins. Then the lymphatic drainage. So the lymph vessels follows the arteries and most of them they drain into the pancreatico-duodenal lymph nodes. So they drain into pancreatico-duodenal nodes. So these will be lying on the inner curve of the duodenum. That is here. We have the pancreatico-duodenal lymph nodes. And from these, the efferents will drain into the celiac and superior mesenteric lymph nodes and finally into the cisterna chyli. That is about the lymphatic drainage. So the nerve supply sympathetic is derived from T6 to T9 as well as the parasympathetic is by the vagus from the celiac and superior mesenteric plexus. To that it supplies. So here we can see this is the duodenal ulcer. So duodenal ulcer, we learned that it is more common in the first part. Okay, so duodenal ulcers, they are basically the erosions, inflammatory erosions. Okay, so they are inflammatory erosions which we see. So first part, because first part I told you it is supplied by the end artery. So that is why it is more common. And the other reason why it is common is it is the part which is going to receive the heavy load of acid, right, from the stomach. The acid chyme comes from the stomach, is in first contact with the first part of the duodenum. So the first part of the duodenum will show, okay, so normally it will show the duodenal cap. So when there is an ulceration, this cap, okay, so this duodenal cap is said to be deformed. It will be deformed. So when there is ulcer, the duodenal cap is deformed, okay. Duodenal cap will be deformed. So normally otherwise we see the duodenal cap here. So this is the cap. So here also you have to remember that the bleeding from these duodenal ulcers is very common. Okay, so due to continuous erosion of the lesion, and sometimes this can cause the erosion of the gastroduodenal artery. Okay, gastroduodenal artery, and that can lead to severe hemorrhage. Okay, severe hemorrhage into the peritoneal cavity also, which can be fatal. Then we have a congenital condition known as the duodenal diverticula. So this is a congenital. So it is always seen in the medial wall of second part. So this is basically due to the herniation of duodenal . Okay, it is the herniation of the duodenal lining through the gaps in the muscle coat, the muscular layer. Okay. So at that point, the arteries and the ducts will pierce the wall. So this mucosa will project to that. Okay. So duodenal mucosa will project, and it causes what we call it as the duodenal diverticula. So the pain arising from the duodenum is usually localized. The referred pain is around the epigastric region. So that was all about the duodenum. So next we will study about the closely related gland, which is in the concavity of the duodenum, and that is the pancreas. So pancreas is a soft, lobulated exoendocrine gland. So it is both exocrine plus endocrine gland. So here the exocrine part of the pancreas secretes the pancreatic juice, while the endocrine part will be secreting the hormones like insulin. So why is it called pancreas now? So if you see the pancreas, okay, pan means in Greek all, okay, and creas means flesh-like, okay. So since it looks, the entire thing resembles like very fleshy appearance, it is called as the pancreas. Now what is the function of the pancreas? So the pancreas, it helps in the digestion of all the lipids, carbohydrates as well as proteins, whereas the pancreatic hormones will maintain the glucose homeostasis. So that is the main function of the pancreas, right? So coming to the location, where does the pancreas lie? So pancreas is almost horizontal, okay, in the posterior abdominal wall, occupying the epigastric as well as the left hypochondriac region. So it almost lies at the level of T12 to L3 vertebrae. Okay, so extends from T12 up to L3 vertebrae. So most of this gland, okay, so most of the pancreas is retroperitoneal. It is retroperitoneal. The tail part here, the tail part lies within the linorenal ligament. So now here the pancreas will have 4 parts. So this is the head. Okay, so this is the head. This is the process that we call it as the uncinate process. Then we have the neck, the body, and the tail. Okay, so the body also will have a small projection, that is a process which we call it as the 𝗕𝗵𝗵𝗀. 𝗕𝗵𝗵𝗀. So this pancreas, it measures about 12 to 15 centimeters in length. Okay, in length is about 12 to 14, width is about 3 to 4 centimeters, thickness is about 1.5 to 2 centimeters, and weight is about 80 to 90 grams. Okay, so that is its measurements. And if you see, it is like a J-shaped or retort shaped. Okay, it's like a retort shaped which is placed within the concavity of the second part, duodenum. So first coming to the head of the pancreas. So head of the pancreas here, if we see, it is in the C-shaped loop. Okay, basically in relation to the second part. So entire C-shaped loop, within the C-shaped loop of the duodenum, we see the head of the pancreas. So this head of the pancreas, I will not go into details of the borders and surfaces since it is not of much importance for your exam as such, but certain important structures which are in relation to the head portion. Okay, so we will just see to it. So here along its superior border, if we see, we will have the first part of the duodenum. So the superior border here is the first part of duodenum. And we will also see the superior pancreatico-duodenal artery. Okay, so plus superior pancreatico-duodenal artery. Pancreatico-duodenal artery is seen there. The inferior border here, okay, it is related to the third part of the duodenum, as well as to inferior pancreatico-duodenal artery. So this is in relation to the borders. Then the right lateral border, if you see the right lateral border, it is related to the second part of duodenum. Okay, as well as there will be the anterior and posterior pancreatico-duodenal arterial arcade will be present. So if you have noticed, so along its borders, there is a part of the duodenum as well as there is an artery also. Then here, anterior surface of it, okay, anterior surface of it is related to gastroduodenal artery, gastroduodenal artery, then the transverse colon, then the root of transverse mesocolon, and down we will have the jejunum here. So this is the root of transverse mesocolon, okay, and jejunum. So that is on the anterior surface. Posterior surface relations are important. So posteriorly we will see the inferior vena cava, the left renal vein, as well as the bile duct. Okay, so these tubular structures we will see: inferior vena cava, left renal vein, and bile duct. And also we will also see the right crus of diaphragm. So these will form the posterior relations of it. So here the uncinate process, okay, so the uncinate process will be related to anteriorly. If we see, we will see the superior mesenteric vessels, vessels, and posteriorly it will be related to the abdominal aorta. So here we can see the posterior. Here it is related. Okay, so here we see the inferior vena cava and we'll have the posterior. So this is actually the formation here. This is in relation to the neck of the pancreas. Okay, we will see. So inferior vena cava will be forming the also a part of the posterior relation of the head of the pancreas. So we are seeing the inferior vena cava. So this is the inferior vena cava. And here is the bile duct, which form the posterior relations. So these structures, they form part of the neck. So when we see the neck is slightly constricted part of the gland and it is about 2.5 centimeters. Okay, so the neck portion, it is about 2.5 centimeters long. So here the anterior surface of it is related to the pylorus. Okay, so anterior, it is related to pylorus, and posterior surface will be related to, it is related to the portal vein, formation of portal vein. So when we saw here previously, so we can see here the formation of the portal vein by the splenic. This is the splenic vein. Okay, and this is the superior mesenteric vein. Okay, so this is the event which occurs behind the neck of the pancreas, that is the union of splenic vein and superior mesenteric vein forming the portal vein. So that we see posteriorly, which we can see here. So this is the postportal vein. And the upper border will be related to, okay, upper border is related to the first part of duodenum. And the lower border is related to root of the transverse mesocolon. Root of transverse mesocolon. So those are the relations of it. So that way the head, relations of head and neck are very important. So we have only discussed those two things. Next, coming to the ducts of the pancreas. So they are of importance here, ducts of the pancreas. So we have two ducts, the major and the minor pancreatic duct. Okay, so the major pancreatic duct, we call it as the duct of, this is the duct of Wesson. And this is the minor pancreatic duct, which we call it as the duct of Santorini. So this main pancreatic duct, if you see, it begins at the tail, okay, at the tail of the pancreas and traverses the entire length of the pancreas, okay, and near the neck, it will turn downwards and it will enter into the second part of the duodenum where it is joined by the bile duct, okay, there, and it forms what we call it as the hepatopancreatic ampulla. Okay, so it forms the ampulla of Vater or hepatopancreatic ampulla. It is also called ampulla of Vater. And this one will open, okay, at the summit of the major duodenal papilla. So major duodenal papilla will be around about 8 to 10 centimeters from the pylorus. So here if you see, it receives these tributaries, okay, or the smaller ducts throughout its length, and that gives a kind of herringbone pattern. Okay, this is called as the herringbone pattern. So in about 90% of the individuals, okay, you have to remember 90% of the individuals will only have the duct of Wesson. It will be the only pancreatic duct. Next is the duct of Santorini. So Santorini begins here, if you see, near the head, lower part of the head of the pancreas, and it will run upwards and medially, and then it opens into the, crosses the major duct and it opens into the minor duodenal papilla. So, minor duodenal papilla will be about 2.5 centimeters above the major duodenal papilla. So, in about 40% cases, it will be communicating with the major duodenal papilla. So, that is about the two ducts. Okay, so when we see the development here, why we see them that way is, so we have the two buds, the ventral bud and the dorsal bud. So the ventral bud will be forming the head, the uncinate process, okay, whereas the dorsal bud will be forming the neck, body and tail of the pancreas. So when they both, after the rotation of the duodenum, both the buds will unite. So when they unite, what happens? Here there will be formation of a communication between the duct of the ventral bud and the duct of the dorsal bud. So the major pancreatic duct will be formed by the duct of the dorsal bud, the communication between the duct of dorsal and the ventral, and the duct of the ventral bud. Okay, so all the three portions will join to form the major duct. So a small portion of it will form. Okay, here whatever the remaining will be forming the minor. So coming to the arterial supply, so the pancreas is a very highly vascular, okay, it is highly vascular. So it is supplied by the splenic artery, so this is the splenic artery supplying it. So splenic artery is branched from the celiac trunk. So here the splenic artery gives many branches, okay, out of which one branch is very large, which we call it as the arteria pancreatica magna. Arteria pancreatica magna. Okay, and a similar branch which will be running towards the tail, we also call it as arteria cauda pancreatica. So these are the main branches from the splenic artery which will be supplying the pancreas. Other than that, we have the superior pancreatico-duodenal artery, which is a branch from the superior pancreatico-duodenal artery. So this superior pancreatico-duodenal artery is a branch from the gastroduodenal, and we have the inferior pancreatico-duodenal artery. Inferior pancreatico-duodenal artery, which is a branch from the superior mesenteric artery. So these superior inferior pancreatico-duodenal arteries will be dividing into anterior and posterior branches supplying the surfaces of the pancreas. Then the venous drainage is of the pancreas, so it follows the veins follow the arteries and they finally drain into the splenic vein, the portal vein, as well as the superior mesenteric vein. The lymphatic drainage from the pancreas, it follows the arteries and drains into four groups, that is the pancreatico-duodenal, pancreatico-splenic, drains into pancreatico-splenic. Okay, so this is the pancreatico-splenic nodes are the main nodes. Then we have the celiac nodes. And then we have the superior mesenteric nodes. And pyloric nodes. Okay, so these are the four groups of lymphatic nodes which do the lymphatic drainage of the pancreas. So nerve supply is both bisympathetic and the parasympathetic. The sympathetic is vasomotor mainly, whereas the parasympathetic is in the secretion, controls the pancreatic secretion. So the carcinoma of the pancreas, okay, coming to the clinical correlation, carcinoma of the pancreas is more common. So it is CA head, okay, head carcinoma, it is the common one. So since it compresses, okay, so in that region it compresses the bile duct. If you see, there is compression of the bile duct. Compression of the bile duct, and that leads to persistent obstructive jaundice. It leads to what we call as persistent obstructive jaundice. So the compression of the bile duct, okay, because of the carcinoma head of pancreas. And sometimes it can also involve the portal vein, okay, or the stomach there. So the pancreas can involve these structures also. Then there is a condition, common condition, which we call it as the pancreatitis. Can be acute or chronic. Pancreatitis, okay. So pancreatitis is basically the acute inflammation of the pancreas. So there is the inflammation of the pancreas. So what can be the cause? It occurs due to obstruction of the pancreatic duct, okay. So if there is an obstruction of the pancreatic duct, and in alcoholics, okay, then also because of viral infections like mumps or any trauma. Now this condition, pancreatitis, is a serious condition because what happens is the pancreatic enzymes, okay, so the activated pancreatic enzymes, because of this inflammation, okay, pancreatic enzymes, what can happen to that? It can leak into the substance of, so this will leak into the pancreas, and that will initiate autodigestion, okay, autodigestion of the gland. Okay, that's why it is a very serious condition. Okay, so because of the inflammation, there is the release of activated pancreatic enzymes which into the pancreatic substance, and that will lead to autodigestion. So the patient usually presents with severe pain. Okay, so there is severe pain in the epigastric region, radiating to the back. Okay, then there is fever, nausea and vomiting. So here the serum amylase levels will be very much raised. Okay, it will be very much raised, serum amylase levels. So coming to the image-based MCQs. So here the marked segment is, okay, so here actually the marked segment was this one. So it is the third part of the duodenum. The structure opening at the marked site. So it is here. So it is the bile duct and the pancreatic duct join to form the 𝗨𝗵𝗺𝗏𝗵𝗺𝗏 ampulla of Vater. The arterial arcade shown represents an anastomosis between, okay, anastomosis between the branches of celiac trunk and superior mesenteric artery. That is between the superior pancreaticoduodenal and inferior pancreaticoduodenal arteries. The uncinate process lies posterior to. Which are these vessels? They are the superior mesenteric vessels. The most likely embryological causes, okay, so what has happened, this we call it as the annular pancreas, where there is failure of rotation of the ventral bud, so it will wrap around the duodenum. Okay, so that is the failure of rotation of ventral bud. So that's a wrap on today's session of duodenum and pancreas. So these revision series get you one step closer to the NEET PG dream, to realize your NEET PG dream. So stay consistent, stay focused and trust in your preparation. I'll see you in the next session.